as a result of which the plasma osmolality decreases and the aqueous becomes more hyperosmolar relatively. That is a result of which there is a fluid efflux from the cornea, which results in slight reduction of the CCT post-HD. These are all transient changes that we see post-hemodialysis.
Thank you.
So there is a fluid shift from the cornea. There is an efflux of the fluid from the cornea, which strongly correlates with the systemic fluid loss that happens in hemodialysis. Yes. Okay.
Thank you. And the fourth speaker, Dr. Anand Kumar. Dr. Anand Kumar, Pathak, surgical showdown, GDC absent. Then the combined post PPV pan-retinal endo laser. Are you present? Okay, Dr. Hamleta Udena.
A very good morning to all. Thank you for giving me this opportunity to present the topic. Without a further ado, let's dive in the topic. Neovascular glaucoma, as we all know, is a therapeutic challenge. There are no clear-cut consensus on how to initiate the best treatment to address the different aspects. Treatment steps include lowering of IOP, anti-inflammatory treatment, reduction of retinal ischemia, and inhibition of VEGFs. Vitrectomy with PRP and silicon oil tamponade may also reduce intraocular pressure in eyes with neovascular glaucoma. Aim of the study to determine the safety and efficacy of an integrative combined surgical approach, which included PPV, near confluent full scatter PRP, intravitreal bevacizumab, and transscleral cyclophotocoagulation in a single surgical session. Institutional Ethics Committee approval was taken. It's a retrospective interventional case series conducted in a glaucoma department of a tertiary eye care institution. Inclusion criteria: NVI, NVA, IOP more than 21, BCVA more than perception of light, 18 years or older, blind eyes were excluded. All patients with decompensated neovascular glaucoma and preserved visual function received the intervention. BCVA, intraocular pressure, the number of glaucoma medication was recorded at baseline and at follow-up visits at 1, 3 and 6 months as a part of routine care. Success was defined as IOP less than 21 millimeters of mercury or IOP reduction more than 30% from the baseline with or without glaucoma medication and without the vision loss. Surgical technique: all eyes underwent transscleral cyclophotocoagulation, standard 3-port gauge PPV, near confluent full scatter PRP till ora serrata, intravitreal bevacizumab and air tamponade. At follow-up, retreatment in case of eyes with elevated IOP, first increased AGM to maximum, then repeat transscleral cyclophotocoagulation. In case they fail to respond, then go ahead with tube shunt or trabeculectomy. If elevated IOP associated with vitreous hemorrhage, then repeat vitrectomy, PRP, transscleral cyclophotocoagulation and intravitreal bevacizumab. Patient, if lost to follow-up, completed a standardized telephone survey that contained the following question: what was the main reason for not coming up? What is your current vision function? How many glaucoma drops are you using? Do you have any eye pain? Are you overall satisfied with the outcome of the treatment? Results: 11 eyes of 11 patients were included. NVG underlying conditions included proliferative diabetic retinopathy, retinal vein occlusion, and vasculitis. At baseline, NVI stage 2 in 45.5%, stage 3 in 36.4%, stage 4 in 18.2%. Mean logMAR BCVA was 1.96 at baseline, 1.578 at 1 month, 1.53 at 3 months, and 1.48 at 6 months. IOP decreased significantly from 44 at baseline to 15.91 at 1 month, 19.64 at 3 months, and 15.09 at 6 months respectively. The number of glaucoma medication decreased from 4.73 at baseline to 1 at 1 month, 1.27 at 3 months, and 0.91 at 6 months respectively. 2 eyes had high FEMA at postoperative day 1, both of which resolved on its own within a week. No eyes required repeat PPV or laser augmentation. 2 eyes underwent glaucoma drainage implantation due to uncontrolled IOP within 3 months of primary surgical intervention, and these are the eyes with stage 4 NVI. 2 eyes received repeat anti-VEGF injection to tackle the macular edema. All those 5 patients were lost to follow-up, and these patients completed a telephone survey. Main reason for missed visits were general health issue, long distance to a hospital, and family-related reasons. 4 patients reported overall satisfaction with the treatment, and all these patients were pain-free. Kaplan-Meier survival curve showing probability of failure at 6-month follow-up, success rate was found to be 81.8%. Limitations: small sample size, no control group, so no intra-group comparison of before versus after treatment data. As a retrospective study, it can only inform on future prospective studies parameters and design and help formulate but not answer the hypothesis about association between treatment and outcome. To summarize, visual function remained low in most of the eyes in a study. IOP lowered significantly and reduced the number of glaucoma medication. Conclusion: a single integrative surgery to control ischemia and IOP is useful and safe. It's a potential consideration to be included in the treatment algorithm before proceeding to filtering surgeries in NVG with vitreous hemorrhage. It reduces the patient and healthcare system burden by simplifying the post-operative care and follow-up. With this, it's a wrap. Thank you and have a nice day.
Dr. Sahab, in the logMAR chart, you are showing that the BCVA is decreasing in all the cases. So why? Can you tell me?
Ma'am, all these patients were having the low vision potential. So it was like basic aim was to control the IOP, to steal that time for doing that filtering surgery, because filtering surgery has a higher failure rate in the long run. So best corrected visual acuity was fluctuating up and down.
You have done this endo laser PRP. So you have not done this filtering surgery in these cases?
Only 2 patients required that intervention after 3 months because they have uncontrolled IOP. We haven't done filtering surgery. We haven't done TRAB in that.
So PRP itself will lead to the optic nerve atrophy gradually.
Yes, ma'am. But all these patients were having vitreous hemorrhage. So we ultimately had to do endolaser PRP till ora serrata to reduce that oxygen load.
You did a surgical procedure along with the intravitreal injection. That
Yes.
was I understand.
Yes, ma'am.
So this surgical procedure was endolaser.
Surgical procedure was pars plana vitrectomy along with endolaser PRP along with transcranial
None of the
cyclophotocoagulation.
cases had extra. I mean the photocoagulation outside. I mean no, without doing an endolaser. None of the patients you have taken.
No.
So it was all.
All these were nevi patient. We have done all these 3 interventions simultaneously in the same setting.
So these are all vitreous hemorrhage patients.
Yes.
All
Only
the
posterior segment
neovascular-
pathology patients were taken.
All these cases were vitreous
Yes,
hemorrhage with
yes,
neovascular
yes.
So after your procedure, did you see the regression of the vessels in the iris and the
Yes, it was there.
it was there. Okay.
Thank you.
Okay, and next we come to Hemlata finished. Then we come to hidden epidemic, addressing challenges in glaucoma screening and early detection strategy. Is the presenting author present? Simran. Okay. Next is Dr. Bhavesh Shah.
Dr. Priyanka. Dr. Priyanka.
This one?
Dr. Priyanka.
Okay, Dr. Priyanka Mohanty. So many absent. Then the last, second last of this.
Shivam.
Where's the presenting author here?
Dr. Shivam.
They are giving here. Dr. Shivam Gupta. He's come? No.
Arya.
Then Dr. Arya Wagle. Five, six, seven, eight, nine,
Hello.
10.
Good morning, everyone. The topic I'll be presenting is glaucoma in eye syndrome, surgical results and clinical patterns from North India. So a brief background is that iridocorneal endothelial syndrome is a rare, unilateral and progressive disorder associated with secondary glaucoma, often refractive to medications and surgery. Progressive vision loss from corneal decompensation and glaucoma is challenging to manage, with a high chance of the disorder being misdiagnosed initially. So there is very limited Indian data on surgical outcomes of these patients, but there is an abundance in clinical data. Keeping all this in mind, we designed our study, and our 2 research questions were: what are the clinical patterns of glaucoma associated with eye syndrome at our base hospital that's situated in North India, and how effective are different surgical interventions in achieving IOP control? So we designed our study as a retrospective case series. Patients were diagnosed with eye syndrome and screened between July 2023 to 25, that's 2 years. Baseline demographic and clinical data was extracted, subjected to statistical analysis, and further subgroup analysis was done to compare different surgical modalities and unilateral versus bilateral cases. Inclusion criteria was age more than 18 years, a minimum follow-up of 6 months, complete treatment records, and we diagnosed eyes based on these findings. That was beaten bronze appearance or hammered silver appearance of the endothelium, known as Chandler's, iris atrophy with holes or essential iris atrophy, and presence of iris nodules, that was Cogan-Rees syndrome. Exclusion was glaucoma due to other causes, cases with uncertain diagnosis, causes of other causes of corneal damage, and inadequate records. So we had 72 eyes of 54 patients that were identified and subjected to statistical analysis. Out of these 54, we had 18 bilateral cases and 36 unilateral cases. So the baseline demographics, again, as published literature shows, even we had around 56%, that is a female preponderance, and a slight right eye preponderance between the two eyes. So the mean age in years was 48.3%. Presenting visual acuity was normal in around 28%, mild to moderate vision loss in 25%, and severe loss in 28%. Glaucoma at presentation was seen in around 67% of the cases, and mostly we had closed angles with presence of anterior pars in more than 270 in gonioscopy. In our study, we had essential iris atrophy in 75.5% cases, Chandler's in 19.9%, and Cogan-Rees in 4.6%. Coming to our surgical data, we had 45 eyes that underwent glaucoma surgery, out of which 29 underwent trabeculectomy, that was the major chunk. Then glaucoma drainage device was done in 22% of the patients. The last smallest group was transscleral psychophotocoagulation at 4.4%, and other surgeries such as corneal procedures as well as cataract surgery was done in 4 eyes. So looking at our surgical success by procedure, we had around 75.9% surgical success in our trabeculectomy group, 70% success in our glaucoma drainage device group, and the others were minuscule. So our coming to trab versus tube, our subgroup analysis showed 75.9% success in trabeculectomy with 70% in the drainage device group, but there was no statistically significant difference in both. Complete success was defined as IOP less than 21 without medications, IOP more than 21, less than 21 with medications, and failure of 21 on maximum medical therapy. Coming to the subtype distribution, our non-valved devices had slightly better success compared to our valved devices. And contrary to published literature, we had an unusually high number of bilateral cases. So those underwent a further subgroup analysis. In interest of time, I'll keep this short. Mean age at presentation and the sex distribution was not so different, but there were almost no Cogan-Rees cases in the bilateral group. Primary surgery was trab in 58%, and repeat surgeries, slightly worse IP control, and higher failure rate was seen in the bilateral cases. Even in unilateral cases, the other eye also was found to have primary angle closure disease in almost 9.7%. So to conclude, ice-related glaucoma usually affects females with an essential iris atrophy subtype. It is progressive and refractory to medication. Bilateral cases have a slightly higher incidence of repeat surgery and worse IOP control. And trabeculectomy remains the first choice of surgery in our hands. Thank you.
Did you try laser?
Sorry, sir? No, sir. Usually the cases that came to us had closed angles, so we could not do any laser procedures. But the other eye was found to have
What do you feel about
closure.
the effectiveness of laser?
I'm sorry?
Effective of laser trabeculoplasty in these type of cases?
In early cases where the angles are open, we can go ahead with laser trabeculoplasty, but since the pathogenesis is a membrane developing over the angles, which will eventually close, leading to high pressures, we don't generally go for that.
Less effective. Yeah.
Thank you. And
Thank you, ma'am.
finally, we have to call this up. We finished this. So, yeah. So, I call upon Dr. Abha Gupta. Evaluation of oral vitamin B12 and folate supplementation in open angle glaucoma.
Good morning. So I'll be discussing evaluation of role of oral vitamin B12 and folate supplementation in open angle glaucoma. I have no financial disclosures. So glaucoma, as we all know, can be defined as chronic progressive optic neuropathy with an ICD status of vision loss seen in around 57.5 million individuals worldwide. So the obvious research question for me was, what are the non-IOP dependent factors in glaucoma progression, and is there any role of neuroprotective role of vitamins like B12 and folate in glaucoma progression? The purpose of my study was to analyze the role of oral supplementation of vitamin B12 and folate in open angle glaucoma. It was a prospective longitudinal randomized intervention trial with a study duration of 6 months, sample size 144, and study group being 2. The first was intervention group, which was receiving the standard anti-glaucoma medications along with oral vitamin B12 1000 microgram once a day and oral folate supplementation 5 mg once a day. The control group had patients only on anti-glaucoma medications. On inclusion criteria, patients aged between 40 to 70 years diagnosed with open angle glaucoma, which included primary open angle glaucoma, normal tension glaucoma, and pseudoexfoliative glaucoma on medical management were taken. The data collection parameters included serum vitamin B12 levels, serum folate levels, best corrected visual acuity, intraocular pressure by Goldman appellation tonometry, Humphreys visual field 24-2C, and optical coherence tomography assisted retinal nerve fiber layer and ganglions analysis, both at presentation and follow-up. So coming on to the results, on the demographic profile, maximum patients belong to the age group of 60 to 69 years with a slight male preponderance in both the groups, both intervention and the control group, and 73.6% in the intervention and 72.2% in the control group were vegetarian by dietary preferences. On distribution of diagnosis, again, maximum patient belong to the diagnosis of primary open angle glaucoma and a preponderance for mild open angle glaucomas in both the groups. On the retinal nerve fiber layer analysis, we were able to appreciate that there is a loss of retinal nerve fiber layer in both intervention and the control group. However, the rate of loss in the control group is way more than the intervention group. Similar analysis was done on ganglion cell analysis, which showed that the rate of loss on ganglion cell layer was more in the control group. The change in serum vitamin B12 and folate levels was as expected because we were supplementing the intervention group with the same. So coming on to the discussion, the overall change in retinal nerve fiber layer over time in between the two groups at follow-up showed more retinal nerve fiber loss in the control group. Our study showed that in the intervention group, there was a loss of 1.06 microns in the intervention group and 2.19 micron in the control group over a period of 6 months. So I tried looking into the literature. So there were various cross-sectional studies which did try to analyze the effectiveness of serum vitamin B12 levels and retinal nerve fiber layer thickness. However, all these were cross-sectional studies taking a single snapshot and trying to correlate the thickness and the vitamin B12 levels. Coming on to the ganglion cell analysis, again, in our study, the change in ganglion cell layer in the intervention group was 1.74 microns and in the control group was 2.24 microns over a period of 6 months. And there is a paucity in literature as to relation between the serum levels of B12 and folate along with ganglion cell layer analysis. So yes, we agree our study had a few caveats. So there is no long-term data available on as to what is the effective duration of supplementation of all these vitamins, and it was limited to evaluation of only vitamin B12 and folate. However, there are a few studies indicating the role of other vitamins in the disease progression. The limitation of being a short period of study with smaller number of patients to reflect the effectiveness of supplementation in preventing functional loss in glaucoma. Just to conclude, oral supplementation of neuroprotective vitamins such as vitamin B12 and folate may be helpful as an adjuvant along with conventional anti-glaucoma medications. It may help us answer why patients who have actually received their target IOP still show glaucoma progression, thereby indicating presence of non-IOP dependent factors. A long-term follow-up with oral supplementation along with anti-glaucoma medications may stagger the structural loss and eventually can be seen a less functional loss on visual field analysis. Thank you.
How long was the period of treatment?
6 months, ma'am.
Only for 6 months you have followed
Yes, ma'am.
up.
The problem was, again, there is no literature as to tell what is the safe period of supplementation of vitamin B12 and folate, although both of them are water soluble vitamins. But since with the paucity of literature, it was advisable to take it up for a short period.
So, do you think it will be sustaining if you withdraw the vitamin B12 and this neuroprotection will?
Ma'am, we are still following up the patient to look for the decrease in the VFI over time. There is a slight better VFI in patients in the intervention group, but again, it is difficult to correlate since we have stopped the supplementation.
Any appropriate dosage?
For vitamin B12 and folate, so this was from the literature. This is a prophylactic dose of both vitamin B12 and folate, 1000 microgram once a day, and folate 5 mg once a day.
Okay, thank you. So, I think we can close down the thing. Okay, anyone, the speakers, presenters who have come late, they can present their papers. So, all those absentees are not available here. Okay. Thank you, everybody. It was wonderful to session this judge, to be the judge of this session. And all of you have presented very well. Each of you have done very good job. So I think we wind up the session here and you get your results after the end of whenever the things decides on it. Okay, thank you.